So the next session is about analytical approaches, and I will start here with a quick review because it is so useful and motivates, I think, a categorization that I will talk about, a conceptual breaking down of approaches to estimate causal effects. The counterfactual model, where we have treatment and control or alternative treatments, and a potential outcomes framework, where essentially we observe the outcome in those who get the treatment and we observe the outcome in those who do not get the treatment, but there is counterfactually important information that is contrary to the fact, counterfactual. So here we see in this 2x2 table the outcome receiving treatment, the outcome not receiving treatment. We observe the outcome receiving treatment in those who actually do receive the treatment. We observe the outcome not receiving the treatment in those who actually did not receive the pre-treatment. But for causal estimation, we want the contrary to the fact, unobserved, counterfactual information, how those who have been treated would have behaved regarding the outcome of interest had they not been treated, and how those who have not been treated would have behaved in terms of the outcome of interest had they, contrary to the fact, been treated. And of course, if we have that information, we can estimate average effect sizes of interest, the average treatment effect for those who have been treated, the average treatment effect for the controls. And you see here that we can use that we have observed the outcome under treatment in those who have been treated. We have observed the outcome not being treated in those who have actually not been treated, but we've not observed these two counterfactual states here that we need for the estimation of average treatment effect for those treated and average treatment effect for those not treated, and of course for the overall average treatment effect, which for many purposes we are interested in. We have not observed these states. We can arrive at the overall average treatment effect as a weighted average of the ATT and ATC, and we have the same issue here that we have observed one part and not observed because it was contrary to the fact another part. So whenever the assignment to treatment versus control is not random versus the outcome, we might run into an issue here, or phrased otherwise, in order to derive from these observed and counterfactual states or outcomes and potential outcomes, the information on average treatment effect, we need to make two assumptions. One is that the people who receive the treatment and we observe their outcome under the assumption that they receive treatment are equal to those who did not receive the treatment in the counterfactual state that they actually had received the treatment. And of course, the same is true in the state, in the situation where we observe those who have not been treated in their outcome conditional or not having been treated. We need to make the assumption that those who have actually been treated would have behaved in precisely the same manner regarding the outcome of interest had they not been treated. So this very basic counterfactual framework is a nice motivation or a nice underlying rationale for thinking about different approaches that we have to obtain causal information. Of course, we do experiments for precisely the point that we want to meet these two assumptions, that the counterfactual states are equal to the observed states, and experiments, random experiments, allow us to achieve that, at least with large numbers, that we balance all the factors, whether we can observe them or whether we cannot observe them, that are relevant for the outcomes. So selection effects into treatment versus control do not play a role in randomized experiments if they're well conducted, and we have completely achieved balance between the control and the intervention group. So we believe that once we have randomly assigned, there are no observed or unobserved confounders of the relationship that we are interested in from some exposure, social experience, economic experience to the outcome. And an experiment is something that is a manipulation where a experimenter, a researcher, a scientist intervenes in this world and assigns a treatment and assigns not getting the treatment to groups of people or individuals. And we sometimes in life have the opportunity to have something that is very much like an experiment, with the one major difference that the assignment to control and treatment is not under our control, not under the control of the researcher, but it has been assigned by nature, by policy, by accident, in a way that we think mimics in a randomized experiment. And this group of quasi-experiments, I think this group of designs and study approaches offers potential to analyzing health and demographic surveillance data, and I will give a few examples of what one can achieve with these methods. And I think the mainstay of our analytical approaches in health and demographic surveillance sites have been non-experiments, where we have no quasi-experimental opportunity nor any real experimental opportunity, but we have observed many of the potential confounders of a relationship between social experience, economic experience, and a health outcome, for instance, HIV or TB or general mortality. And we can control for these observed confounders and hope that our controlling brings us very close to a situation where there's no unobserved confounding, no confounding of that estimated relationship by factors that affect both whether a person received a treatment or was of a certain income status or had a certain level of wealth and the outcome of interest, for instance, a morbidity outcome or a mortality outcome. Randomized controlled trials, I think, are also interesting in the context of health and demographic surveillance sites for the following reasons. In some sites in the past, there have been experiments, there have been randomly assigned interventions to certain groups of children, for instance, or randomly assigned to patients who we still see in the community now many years later in longitudinal follow-up in our population-based cohorts. And I think there's a largely untapped opportunity here that as long as we can still track the exposure that was at some time in the past randomly assigned, we still observe the person as being part of the ongoing population cohort, we can use the exposure information and long-term follow-up on many outcomes to get to causal effects on factors that we're very interested in. So many years later, we might, if a grant was randomly assigned at some point, or if a new approach to schooling was randomly assigned, we might many years later be able to see outcomes regarding health and health-related behaviors through the surveillance lens. And I think that's important to keep in mind for you at individual HDSS to think through what maybe 10 years ago had been done in terms of randomized controlled trials and what potential outcomes could be that haven't been looked at or that haven't been looked at with that length of follow-up, to revisit and redo the analysis that is, of course, very strong if the exposure has been randomly assigned. Of course, there are many limitations of randomized controlled trials. Often they're not possible. Often they are simply not feasible or ethically not doable because we cannot randomize a harmful experience to people. We cannot deprive people, for instance, randomly of social capital to observe the outcome of interest, possibly the incidence of myocardial infarction. And randomized controlled trials are usually a black box where we have an exposure and an outcome, but the pathway from exposure to outcome is not immediately visible to us, and it takes additional analytical approaches and techniques to gain some insight into what is on the pathway, what transmits the exposure to the outcome. Nevertheless, I think there are these opportunities in health and demographic surveillance sites to think about past controlled experiments with random assignment, but also thinking about what we can do now going forward. Because what we have in the health and demographic surveillance site is, of course, a very rich and comprehensive set of outcome variables that we observe and potential control variables regarding baseline measures, which can improve the efficiency of our statistical estimation in randomized controlled trials, controlling for baseline differential distributions in control and intervention groups on observed factors. So we can, of course, consider for many aspects of linking social experiences, economic experiences to health and health-related outcomes, randomly assigning those. For instance, we could consider offering randomly selected households in a demographic surveillance area a new savings mechanism. We could say, you household now have access to save money in a certain approach, and other households, at least initially, are not assigned this opportunity to access savings or an investment opportunities, right? We could offer randomly selected certain households a opportunity to take out capital, to invest in a business, to invest into schooling, and we could then observe the impact of these interventions on an outcome of interest, such as a HIV incidence in youth or youth pregnancy. So there is an opportunity here, I think, that is also largely untapped in HDSSs to add to the surveillance a random exposure and to measure through the surveillance, as we already do, many of the outcomes that we are interested in regarding health and health behaviors. Here's an example from David Canning and colleagues where they exploited a random opportunity in the MATLAB health and demographic surveillance site, which is of course one of the oldest health and demographic surveillance sites in Bangladesh, where many years ago a vaccination intervention was randomly assigned, and it is still known which children received the vaccination at the time and which children did not. And now Canning and colleagues use that information to look at the outcome here of interest, which is a health to wealth link, if you will. They look at schooling outcome and they see that the treatment, the vaccination intervention here causally affected schooling, that it reduced the proportion of non-schooling, and it increased secondary and primary schooling attainment in children. And that's a very powerful result because of the random assignment of the initial intervention. So much stronger, in my opinion, than anything we could have done by regressing the schooling outcome on merely the observed having had the vaccination versus not having had it, in the absence of random assignment of the vaccination at the point in time when the trial was conducted. And of course, these other studies have also been published, but here they are improving our approach to estimate causal effects of vaccination on schooling. When we think now about the second category of opportunities that we have to do analysis in health and demographic surveillance sites, quasi-experimental studies, there's a range of definitions what a quasi-experiment is, but most definitions include an element that is principally important, which is that the assignment of an intervention was exogenous to an outcome of interest, that it was outside the system. It was as if randomly assigned by force of nature, by policy, by the way we measure variables, and I will go through examples of quasi-experiments. So for instance, here looking at the King et al. Definition from the political and social sciences, an observational study. A quasi-experiment is an observational study with an exogenous explanatory variable that the investigator does not control. And the second part, I think, is also important. The as if random assignment is not through us, not through a researcher, an investigator, but through another force. But essentially, it is the same as if we had randomly assigned with a random mechanism, for instance, looking at random numbers in Stata, the intervention of interest. And here is a set of quasi-experimental studies. We have, of course, natural experiments where nature or policy has randomly assigned an intervention or an exposure. We have instrumental variable analyses where we can identify a variable that we can test in affecting an exposure of interest. For instance, how high a person's income is. And we know from theory, from thinking through plausible relationships in life, that we have a very strong case in claiming that this variable does not independently, that is not through the selection into the exposure mechanism, affect the outcome of interest, for instance, HIV acquisition rates or mortality. And whenever we have such an instrumental variable, we then have an opportunity here to estimate strongly causally an effect of an exposure on an outcome of interest, for instance, household wealth on health. Regression discontinuity is a very different quasi-experimental approach, and I think some of your readings went into some detail how regression discontinuity works, but it starts with the fascinating thought that whenever a treatment, an exposure, for instance, a social intervention or an economic grant, is assigned on a threshold, we have an opportunity to look in small neighborhoods below and small neighborhoods above the threshold at people who are essentially equal because they're randomly assigned. And this random case is made because we have measurement error, for instance, in how we ascertain where on a continuous scale, above or below the threshold, a person falls. And those people who fall just below the threshold versus those who fall just above the threshold are likely to have been randomly assigned by chance, by measurement error, by all the factors that we cannot control for, but that affect where I am. For instance, in whether my income at a particular point, when an income metric is used to give me a grant or not, a deprivation index is used, or a means testing approach is used to give a family a grant using available income information. Whether my income just exceeds or is just below that threshold may be very independent of any potential confounders of the relationship, but the assignment might matter for my long-term health outcomes. And I'll give another example from a study that we have conducted using regression discontinuity in a health and demographic survey insight later. Interrupted time series studies are very analogous to regression discontinuity, but use as a assignment variable or a forcing variable, that's the term often used in this literature, that forces people into the treatment or non-treatment state time. And then there are potentially discontinuities across time in the effect that we are interested in, and they are potentially causally related to the discontinuity in the exposure that was assigned before a certain period of time but not after, or vice versa. And then there are studies that are maybe weakly quasi-experimental, and difference in difference studies are common here, or maybe as a general term we can talk about difference studies, where we observe an individual repeatedly over time and thus have an ability to control for everything that makes this individual special, all the individual characteristics that are invariant over time. So who I am stably over time we can control for in estimating the causal effect of a social experience on an outcome, because we observe me over time and we observe the outcome over time. So the estimation now of a causal effect relies merely on changes over time in the exposure of interest, for instance, school attainment, or being given a social grant or not, and an outcome of interest, for instance, my risk of acquiring HIV over time, but we can completely control for all the factors that make me special that do not vary over time. And of course, this is a comparatively weak quasi-experimental approach, because unlike the others that are on this list, it does not allow for, potentially, the complete set of unobserved potential confounders. We can still have confounding in a time-varying manner in differences studies, and we assume, in order to obtain a causal effect size estimate, that trends are parallel, that the trend is the same in those who receive and those who not receive the treatment over time. As an example here from general public health and medical literature, McClellan et al. In JAMA used a very creative instrumental variable approach that might be replicated, for instance, in health and demographic surveillance sites, where they looked at the effect of a certain treatment that is available in some hospitals but not in other hospitals in the United States, and on outcomes post-myocardial infarction, how good the health outcomes are after a heart attack. And the instrument, that is the use an instrumental variable to predict whether a person receives one treatment or another one, available in one hospital but not in the other one, using the relative distance between hospitals. And we might have been very concerned had they used the distance of a household to the nearest hospital as an instrumental variable, because that distance can likely be related with other things that affect the outcome of interest, myocardial infarction. But the relative distance between the nearest and the second nearest hospital, which is likely very important in deciding which hospital a person goes to when they have the symptoms of a myocardial infarction, is very unlikely to be related systematically to an outcome of interest, and is very likely random versus that outcome. But it probably matters, and that's testable, and they test it and find that indeed it does determine which hospital you go to. Of course, if the nearest hospital offers a new approach and the second nearest does not, you will be going to the nearest if you believe that the new approach is a better approach. But if the second nearest offers the new approach, which you believe is better, and the nearest does not, the relative distance between the nearest and the second nearest will determine whether you receive the new approach or not. We have recently, in an article, exploited time and space variation of antiretroviral treatment coverage in rural KwaZulu-Natal to estimate in a non-experimental study the effect of antiretroviral treatment at the community level on an individual who initially in this surveillance is HIV negative, and we now observe that person over time repeatedly in acquiring HIV or not acquiring HIV, whether it matters for this initially at baseline uninfected individual, whether they live in a community with a relatively high or relatively low antiretroviral treatment coverage. And we see here in this chart that over time, antiretroviral treatment coverage by this color scheme increases. Green is coverage low, below 10%. Orange is coverage that is very high, above 40%. Dark orange, light orange between 30 and 40%. So we see how ART coverage overall moves, but there is a lot of heterogeneity both over time and at any point in time geographically in the distribution of ART coverage. And we know where people live. We have geolocated them in their households. We know thus to which community coverage they are exposed to. And we can thus estimate the effect over time of antiretroviral treatment coverage on HIV acquisition. And we see here a very large and highly significant effect when you live, for instance, in a community where 30 to 40% of all HIV infected people are receiving antiretroviral treatment. You are 40%. Your hazard is 40% less to acquire HIV than had you lived in a community where less than 10% of all HIV-infected people are covered with antiretroviral treatment. Now, while we control for many time-varying variables here that could potentially confound this relationship between community ART coverage and HIV incidence, HIV acquisition in the individual. The initial assignment to a community is not random, and it is not very likely, in my opinion, but not inconceivable, that a person moves to a community with high coverage when, for instance, they are at higher or lower risk, absent of moving, to acquire HIV. So there may be a selection, a self-selection of individuals that is related to the outcome of interest, which is HIV acquisition, into communities of high versus low ART coverage. And in this situation, we might doubt that what we have found here is really a causal effect. So we are now embarking on a study where we try to look for instrumental variables that can, through identification of a variable that affects where you are in a low or high coverage community, which does not also affect the outcome HIV acquisition, estimate the causal effect more strongly. And such a quasi-experimental opportunity, I think, would strengthen our belief in what we have uncovered here being a causal effect. And an example could be the distance to the nearest clinic where ART is available. The closer we are to such a clinic, the more higher an HIV-positive person is to be on ART. We know that, we have tested that. But now we need to believe that the distance is random versus the outcome HIV incidence. And I think we have a strong case that in this particular setting it could be random, because we understand well how these clinics were placed. I looked after this ART program for some period of time when we brought new clinics online, and we did not consider factors that are, in my opinion, plausibly related to HIV incidence, but we considered whether a nurse had the opportunity at some point in time to take an examination qualifying her as an ART nurse, whether we were able to hire at some point in time an additional driver, then we could bring on additional clinics or not. And these factors are plausibly unrelated to HIV incidence, and I would argue highly plausibly. Another example of a quasi-experimental approach, and again, in my opinion, an opportunity that has been underutilized in health and demographic surveillance side, is regression discontinuity. And I talked about the sort of principal concept of regression discontinuity. Here's an example from the literature by Almond et al., where they looked at a treatment in the United States that is assigned to infants, to newborns, when they have a certain birth weight below a threshold of 1.5 kilogram. They will not receive the same treatment if they're just above that threshold, 1.5 kilogram. And now by comparing the individual children in their outcomes who are just above that threshold versus who are just below, and this trend might give us here an idea going from left to right where an individual child would be had they been just below in their birth weight of that threshold. The comparison of those just below and just above give us a causal estimate of the effect. If we believe that birth weight here is in that small neighborhood around 1.5 kilogram randomly assigned because there's measurement error in the scales, the child might accidentally have swallowed a little bit more, a little bit less water. The mother might, at the point of measurement, have given already some breast milk, or might not have done that, or the child was left out in a hot environment and sweating for a little bit longer versus not. So many factors that jointly might make up randomness, if we believe that randomness philosophically is the unmeasured, all the influences of all the things that we cannot measure, or if philosophically we believe that there's true randomness, even with best measurement efforts, and if we could measure all the determinants of birth weight here, there would still be some randomness in small neighborhoods around that threshold. In either case, we have an effect size here in achieving a mortality reduction. On the y-axis, we see the 20-day mortality, which is here higher in those not receiving the treatment just above the threshold versus those receiving the treatment just below the threshold. And here is, from a health and demographic surveillance side, from our own work, an example that regression discontinuity can be very powerfully used to estimate treatment effect sizes. What is an opportunity, of course, as we know in health and demographic surveillance sites, is that we often have a ability to see people both as patients and as community members. We see them in receiving antiretroviral treatment, and then we see them as household members, as social actors in the community, and we see them in their mortality and morbidity outcomes through the health and demographic surveillance. And here we have used the standard cut-off threshold of 200, which was in place in South Africa in the past. Of course, now it has shifted to higher levels of CD4 count, where individuals below 200 were assigned to receiving antiretroviral treatment. Those above 200 were assigned to not receiving antiretroviral treatment. Of course, that's not a deterministic assignment. Some of those below will not receive, out of their own choice, for instance, the treatment. Some those just above might still receive the treatment because, for instance, they're very sick, and then the doctor, of course, can overrule this decision allocation to treatment versus not. But we see that there is, in the cumulative probability of ART initiation here, after 3 months, for instance, a very steep gradient just across this threshold. So it does matter whether you fell just below or just below the threshold. And for later treatment probability, that is still true, even 24 months after the point of CD4 count measurement. Being just above is worse if your outcome is good when you receive treatment than being just below. And we can use that to estimate the causal effect of the antiretroviral treatment scale up under this cutoff of 200 here on mortality outcomes. And we see the effect size, which here is the difference between these two lines. These are the regression estimated smoothed regression lines, and that is a significant and large reduction in mortality due to that treatment under this threshold rule of about 30%. Now we have experiments, we have potentially untapped opportunities in health and demographic surveillance sites regarding exploiting past experiments and stimulating in a random fashion an exposure. And we have quasar experiments, and I think there are many, many opportunities when we think about this armamentarium that we have in the HDSSs, where we can, with new combinations of data and new approaches to linking data, generate very powerful quasar experimental opportunities. And of course, we commonly work with non-experimental data or with non-experimental study designs. But I want to also go away from this post-positive view of the world to a more constructivist view, where we are maybe interested in alternative approaches to establishing causality, just to remind ourselves that not all we are doing is necessarily quantitative, but that qualitative approaches from a very different philosophical approach can add a lot of value to what we can learn in health and demographic surveillance site, including in establishing causal relationships between social experiences, economic experiences, and health outcomes. And this is thinking about causation as a process that evolves in steps, that evolves along a pathway where we can observe minimal steps, and we can think about the mechanisms in a lot of detail that in the experimental or quasi-experimental studies remain only partially seen. So once we can draw out each and every step in a causal chain, we have also established a case for causality. And Goldthorpe makes this case as that the counterfactual model implicitly always assumes consequential manipulation. So we manipulate, or nature manipulates, and then we observe the consequence. But there are, of course, causal relationships where the variable that social exposure, social capital, education can never be manipulated, and nevertheless it can have a causal impact. And the counterfactual models settles, in Goldthorpe's opinion, too easily for causal claims without considering the mechanism that brings about this causal claim. And he proposes that we should instead follow a sequence of research where we establish what we want to explain. We hypothesize the generative processes leading from social capital to mortality, and then we test these hypotheses. And in doing so, we achieve causal insights. And the approach here to judge whether in a qualitative study, for instance, we have achieved causal insight is one of saturation in coming to the smallest unit or the smallest step that we find plausible and that we think we know in a scientific field. We know certain relationships at a very small causal step to something not very distal from the exposure. And by linking such small steps where a field, a scientific community has no disagreement to each other, we might actually be able to make a very strong causal claim between a exposure and a distal outcome. So in summary, I think I have shown and made a case that health and demographic surveillance sites have a rich set of data on social and economic experiences, and of course also on the outcomes that we are interested in public health and the health research community, mortality, morbidity, HIV acquisition, body mass, blood pressure, and we can use that for many types of analysis. The mainstay of analysis, I think, in health and demographic surveillance site has been to this date non-experimental studies where we control for some set of observed confounders in trying to establish a causal link between an exposure and an outcome. But I think we have underused quasi-experimental and experimental opportunities which we can exploit in the future, and sometimes based on past studies and opportunities that are already there, and sometimes based on opportunities that we create through adding on random exposure experiences to the existing instrument that the health and demographic surveillance sites are. And in addition, I think nested qualitative studies that approach causality from a point of view of finding out about mechanisms and finding about small steps linking up an exposure to a distal causal chain, to a distal outcome along a causal chain may be very useful for offering an alternative and explaining view on the link between an exposure and an outcome of interest. So one interaction that I'm hoping for is to meet you in some of the health and demographic surveillance sites where you work, or at the in-depth meeting that is upcoming in Johannesburg, or future in-depth meetings. Of course, I know many colleagues from many health and demographic surveillance sites such as Agincourt in South Africa, Nafrongo in Ghana, Ifakara in Tanzania, Nuna in Burkina Faso, and look forward to meeting many of you. The second opportunity I think that we have to interact here is more distance-based, but nevertheless potentially very meaningful and useful. That is your assignments, which I will create and look into, and which will give us an opportunity to exchange thoughts and ideas and jointly learn. Thank you.